Let's go ahead and get started, and people can catch up as they log in. So we really appreciate that you're joining us today. So my name is Sherry Lippman, and I direct the Intervention and Implementation Science Core at UCSF. We're sponsoring this event in partnership with the UCSF CFAR Implementation Science Working Group and the UCSF Department of Epidemiology and Biostatistics Implementation Science Program and PRISE Center. Today's discussion on study designs for evaluating the impact of COVID-19-related interventions and interruptions is actually the final segment of our four-part series focused on adapting HIV programs and other interventions to the realities of COVID-19. So presentations from the previous segments in our series are available on the CAPS website, and Rochelle Blanco, who's on the call today, can be contacted if you have questions about how to find them. We've lined up an amazing set of speakers for you today who are going to lead us through discussing appropriate study designs for COVID intervention evaluations, as well as when to adapt those designs in studies that were disrupted by COVID or pivoting to COVID that were not originally designed as COVID research. So we're going to have our first two speakers speak, and then we're going to take some questions, and then we'll have our second two speakers start up as soon as those questions have been answered. Rochelle just posted her email address for anyone who has questions. Thanks, Rochelle. So if you have questions, you can put them in the chat, and or we can also call on you if you want to ask your own question. And with that, I think we'll go ahead and get started. So our first speaker today is Kristefer Stojanovsky, who is a fifth-year Ph.D. candidate in the Department of Health Behavior and Health Education at the University of Michigan School of Public Health. His research in the US and Europe interrogates the role of stigma in driving HIV risk and infection through the use of system science, computational modeling, and legal epidemiology, which I have to say, as an epidemiologist, I'm not sure what that is. Maybe you can tell us. So Kristefer's work is focused on direct application and translating research into policy relevant decision making. He's currently an RWJ Health Policy and Research Scholar and an NIMHD Global Health Equity Fellow. We're really happy to have you here today. So why don't I hand it over to you to share your screen.
No, thank you, Sherry, and thanks everyone for having me here. I'm excited to be here with y'all on this talk. And yeah, we can definitely get into some legal FE questions later on if folks want to do that. So again, thanks everyone. Can everyone see the slides? Yes, I see head nods. Great, cool. So just to give us a quick rundown of today, the agenda, just some brief introductions, but given that Sherry already introduced me, I won't be going through that again. Challenges of evidence-based decision-making, kind of discussing where we are right now in the world. How do we create science and research to support real-world decision-making? Then we're going to go through some of the types of study designs that are being employed right now around COVID, answering the questions around, what's impactful, what's efficacious, what's effective, and then go through some applied examples as well that Starley and Margaret will go through. So we already have that, so I'll just skip through that. So the challenges we faced. When I was thinking about putting this together, I really went to the conversations that were happening across the globe around kind of what's happening in our citizenry, what's happening in our populace, what are the questions and kind of challenges that are coming up. And, one of the big overarching, I think, factors or issues that we're experiencing right now is kind of this misalignment between policy intention and impact. And I say that in a way that there's a lot of questioning happening around the logic of decision-making. And, I wanted to just uplift this example that came out of New York, where they did an interview with a resident in New York City discussing kind of one of the, his colleagues was looking at him, seeing social media imagery of him being out at restaurants, eating, dining in, and kind of was like, hey, do you know that this actually isn't safe for you? And Josh replies back down at the bottom, was irritated, and not because he was upset that his friend was telling him not to eat at restaurants, but rather he thought it was safe, given that decision makers and policymakers had made the decision to open said restaurants. And so the question becomes is, how do we explain these decisions to the citizenry? How do we support their decision making? And kind of how do we move forward from here, knowing what we know? And you're going to see a similar kind of storyline coming through in the next slide, where Sweden's population, this just came out late last month, where Sweden's population has lost confidence in the way their country has been responding to the pandemic. It's actually dropped nearly half in terms of what the confidence is in their decision making. And interestingly enough, in Sweden at the beginning of November, after months of kind of doing a low touch, not really creating any restrictions, not having any policies around that, they did a complete 180 and are now having enforced restrictions and enforced quarantine in Sweden. And then, just some conversations that are also happening on social media with, what's happening in California right now with decisions to reinforce stay-at-home orders, right, where people are questioning, okay, you can't ride the public transit, can't go on your walk, can't go on the bike, but can go to the mall as long as it's only 20% capacity. And so it's creating confusion and mistrust, I would argue. And so how do we create science that better supports our decision making and kind of supports our ability to live through the pandemic? And then here's another one from Dr. Teresa Chappell, who, is questioning our decision making around Thanksgiving. At the same time, we're telling people not to convene with family at home because it's dangerous. At the same time, restaurants are open and we're allowing folks to eat indoors. And so there's this misalignment between our messaging and our policies. And so how do we create improved science to better communicate kind of what is happening and how we should be responding? And what I'd say is that all these issues call attention to the need for the improved science and the consequences of our collective decision making. I'll go to the next one. And then, not just related to COVID and questions of reopening and all those, but it's also disrupted the way we provide services. So just an example, in Kenya, currently 1.5 million Kenyan adults and children who are living with HIV are suffering from a disrupted supply chain of their medications and treatment. And so we also need to improve our capacity to kind of reopen various services and treatments and prevention efforts also related to HIV. And, another interesting piece that's happening now at the University of Michigan is that the reagents that are also being used for STI testing are also the same reagents that are used to make some of our other tests like COVID testing. And now there's a conversation happening at the University of Michigan of what do we do with STI testing? How do we get STI testing back into our regular services, given that supply chains and things have been disrupted. And so right now at the University of Michigan, STI testing is on the back burner and has been put on hold in the region because of lack of supplies. And then it also leads us to questions about how do we think a little bit more creatively about how we make our decisions. So just as an example for HIV, what opportunity is there for HIV self-testing to maybe play a role in some of the way we provide services now, given that we're living at stay-at-home orders? But there are interesting questions that new study designs, real-world study designs can kind of help us answer. And so why real-world study designs? And what are those? And so at the beginning of the pandemic, COVID kind of really forced policymakers and researchers to make really quick decisions with limited amount of data. A lot of this was retrospective in nature. Observational studies were used often, so issues of causality become a challenge. The type of data that we were able to access and use were limited. And then also the ecologic fallacy, that while we're using population health measures and looking at this kind of from a more global population level, how does that actually trickle down, and what's happening kind of at the individual level? Are those same interpretations able to be made? And then this also challenges the decisions that we're able to make. with the type of science that we're used. And so, you know, back to the point of there's this misalignment between the intention and the impact. And so how can we kind of improve that match? And then also, how do we improve our science and our research methods to support the real world decision making that we need at the present moment? And so what are some of the additional concerns that we're all dealing with right now around this evidence-based real-world decision-making? First and foremost, the pandemic issues are diverse, right? Depending on the localities we're living in, right? We're seeing increasing cases in the United States. However, that varies depending on the state you're in, the county you're in, maybe even in the city. And then globally, right, we're seeing different issues happening around the world. So in Southeast Asia, right, the pandemic looks different than that in Europe and that in the United States. So one size won't fit all. And so how do we create science that is kind of more real world focused, more adaptable, and really kind of understand what implementation looks like? Oops, sorry about that. And so, you know, all the other things that kind of influence these factors too are things like politics, personal values, something Margaret will kind of get into later with choice designs, and kind of misinformation. All these things are wrapped up in shaping behaviors in the way we're participating in our current pandemic and the decisions that we're making. And then, so just a brief rundown on pragmatic trials. So what pragmatic studies aim to do or to assess the effectiveness of policies, treatments, or interventions in real-world practice. So the goal is to provide evidence of the added value of the policy or intervention into routine care or routine practice, while maintaining the quality and strength of the comparisons in the science. So just to kind of go through similarities and differences between RCTs, randomized controlled trials, and pragmatic trials. As you can see here in an RCT, we're looking at what happens under these ideal, really prescriptive controlled settings, whereas in pragmatic trials, we're really focused on real-world circumstances and real-world issues. In RCTs, they're conducted in highly controlled settings. However, in pragmatic trials, it's less, it's a little more loosely controlled, more real-world. How do we understand what's happening in clinics and schools, in all these places where the intervention might take place, and how does that influence the outcomes we're seeing? And in pragmatic trials, we don't look at necessarily placebo, but what is kind of quote unquote the standard of care right now? That is a big question with COVID-19. What is the standard of care for all these decisions that we need to make? And then the inclusion criteria for pragmatic trials are a little bit less restrictive as compared to RCTs. And I think the big thing here that's interesting for the kind of treatment regimen is it's more flexible and adaptable. And really, I think I would say kind of focuses on a person's experience rather than focused on or driven by a protocol. And then one of the other big differences is in RCT, we're looking at efficacy, whereas pragmatic trials, it's effectiveness. So like what's happening in the real world. Again, both can be randomized, which is great, although it changes a little bit differently. And then the validity issues, which are a concern in both, but pragmatic trials definitely focus on how can we generalize these results out to a larger population than who was just studied in the study. And so kind of just to wrap up before I pass it off to Jean, pragmatic designs may offer us the solutions that we need at this present moment and can inform decision-making outside the constraints of a clinical trial. It provides evidence for real-world decision-making, explicitly explores the implementation processes as well. It also strengthens our data quality, particularly focused on external validity, the ability to generalize out. And I would also say offers us the ability to think a little bit more creatively for the solutions that we need at this present moment. And so, but to improve our decision-making, we need data. So what does that data look like? How do we create it? And what are those studies? And that's what Jean will talk about right now.
Thanks, Kristefer. So for those of you who I haven't met, I'm Jean Digitale. I am a third-year PhD student in epidemiology at UCSF. So I'm going to take us back a little bit to discuss the observational designs that were really common at the beginning of the COVID-19 pandemic. And this work is based on an article that Kristefer and I are working on under Margaret's guidance. And so I'm going to talk about the piece that we are trying to move away from. So Kristefer's arguing, okay, we need to move toward these pragmatic study designs, and I'm going to lay the groundwork for what came first. So in the beginning of the pandemic, COVID-19 interventions and policies were primarily evaluated with observational designs, like Kristefer said. So secondary data analysis. And for each of the designs, I'm going to walk through the basics of the designs, a published example in the literature, and limitations of inference for those studies in the context of that example. Next slide. One more, Kristefer, thanks. Awesome. So the first study design that comes up is pre-post. So comparing the outcome of interest before and after the intervention. As many of you know, this requires just 2 data points. It may or may not have a control group. And there is bias if anything else changes during the study period that affects the outcome. So it doesn't account for pre-existing underlying trends, and which is problematic given we're looking at an infectious disease, which infection rates would not be expected to remain stationary during a pandemic. So this example that Kristefer is showing is one of the few pre-post studies I found, luckily, since we consider it to be one of the weakest designs. It is entitled "A Dramatic Decrease of Laboratory Confirmed Influenza A After School Closure in Response to COVID-19." So these authors use a pre-post design to test for differences in the amount of respiratory illness in a pediatric emergency department in Qatar before and after school closures in response to the pandemic. And I'm not sure whether they didn't have COVID itself data available at the time, but they were essentially using these respiratory illnesses to act as a proxy for COVID. Next slide. So their results are found in this table. So they compare the average proportion of positive tests for illnesses such as influenza A, influenza B, RSV, etc. before school closure, so from February 13th to March 14th, to the time period after school closure from March 15th to April 11th. And they concluded that there was a reduction in influenza A and adenovirus transmission. Next. So inference from simple pre-post studies carries a number of limitations. The authors did have some strengths to the study. They included a lag period for influenza A. So a lag period has to be specified for infectious diseases like influenza A or COVID-19 due to the incubation period. It was unclear whether the lag period that they included for influenza A applied to all of the other diseases that they looked at appropriately, however. One potential limitation with pre-post designs are variation in the outcome from seasonal trends. So to mitigate this, the authors compared influenza A rates in 2019 to influenza A rates in the time of the study to demonstrate that this was unlikely to be the explanation for the decrease. And then another major limitation is that most COVID-19 policies came as intervention packages. They weren't implemented in isolation. So here they're assessing school closure, which was the first social distancing measure that the government of Qatar instituted, but it's unclear whether others were implemented during the study that may also have contributed to decreases in these illnesses. So bias from seasonal trends or from concurrent policies could be mitigated by inclusion of a control group, obviously, that was subject to the same trends and policies, but whose schools remained open. The trouble is finding such an appropriate control group. Next slide. So the next study design that we're going to discuss is interrupted time series. So this is one of the most common studies designs that we found when we were doing our literature review. So interrupted time series, as many of you know, use data at multiple time points before and after the introduction of the intervention. Just like pre-post studies, they are biased if anything else changes during the study period that affects the outcome, but it's a stronger design than simple pre-post because it takes trends over time into account. Next. So this graph is a classic ITS. So it compares the level and trends of the outcome present before the intervention to the left of that dotted line to the level and trends after the introduction of an intervention within a group, so the right side of the line. And the assumption is that the pre-trend would continue unchanged in the absence of the intervention. So here there is no control group, you're looking at the change within one group. So again, any change in the observed outcome in level or slope is attributed to the intervention. Next. So it's important to pre-specify the model that you are expecting. So do you expect a level change, a slope change? Is there a lag that you need to incorporate because of infectious diseases? So you should hypothesize a priori what you expect. So for example, with A, there's just a level change in the top left. With B, there's just a slope change, but no level change. With C, there's both, and so on. So if you don't specify a priori what you expect, you can, and instead let the data drive the model, you risk issues of overfitting or potentially things like p-hacking. Next slide. So one example of ITS that we found, there were many, was the social distancing to slow the US COVID-19 epidemic, longitudinal pre-test, post-test comparison group study. The titles made things difficult. You had to look through the methods. So this is really an ITS study, although it's labeled pre-test, post-test if you look at their models, which is unhelpful when you're trying to do a lit review. So the authors assessed whether statewide social distancing measures, defined as closures of schools, workplaces, cancellations of public events, restrictions on internal movement, and closures of state borders influence COVID-19 incidents. Next. So their primary outcome was the rate of change in daily COVID-19 cases in each state, which they calculated on the natural log scale. They transformed the outcome so that they didn't have to model nonlinear functional forms. They did pre-specify a lag appropriately of 4 days after the implementation of the policy to account for the incubation period. And this was based on published estimates of the incubation period at the time of publication. They limited the analysis to 21 days after the policy because some states were already loosening their social distancing measures 4 weeks after the policies were implemented. Next. So these graphs show their ITS models. So the outcome is, for both, is % change in day-to-day COVID-19 cases. And then on the left, they assessed as an intervention the first statewide social distancing measure. On the right, they assessed statewide restriction on internal movement, which is shelter in place or lockdown. So for both of the models, they used mixed effects linear regression with random effects for states to allow for within-state correlation of cases over time. Both models included a dummy for the post-intervention period representing the level change and an interaction of that variable with time representing the slope change. So on the left, with the first statewide social distancing measure, they did not find a level change, but there's a clear slope change. And then on the right, they did not find a slope change, but they found a small level change. So it's interesting because you can see restrictions on internal movement on the right were implemented a median of 11 days after the first statewide social distancing measure on the left. So the post period, the beginning of the post period on the left becomes the pre-period on the right. So you can see that it's already on the right, this before the statewide restriction on internal movement went into effect. The cases were already decreasing and the lockdown really didn't change the rate of that decrease any further. Next. So they did a number of sensitivity analyses to adjust for potential confounding by population density. They adjusted their estimates by state level population density to They adjusted for day of the week to account for weekly periodicity that could coincide with implementation of social distancing measures. They stratified by size of the epidemic in the state at the time of implementation to assess the extent to which early versus late implementation of social distancing modified the effect of the policy. And then they specified a range of incubation periods to ensure that they had specified it correctly. And that they found that their results were robust to the different specifications of their model. Next. So the primary issue with this that continues to come up, like as it did for pre-post, is that they can't disentangle the effects of multiple contemporaneous policies. So we can't ascertain which of the statewide social distancing measures was most effective in reducing case growth, especially given the fact that, like we said, these usually come as a package. It's also difficult to specify the correct timing for the model when we should expect to see that level or slope change. Did we get the incubation period correct for COVID, especially at the beginning when we were more uncertain of what that might be? And how are people reacting to these policies? Are people staying home before the mandates even take effect? Are they waiting a week before they really follow the policies? It's difficult to know at what point the majority of the public is adhering. Further, local mandates could differ from state mandates, and this was a state level assessment. And ITS models could be biased if the amount of testing changed over time, which we know that testing has been ramping up. And so if there was more testing after the intervention compared to before, that could cause bias. Next. So the final design I'll talk about are time series data with a control group. So time series with a control group is commonly analyzed with a difference in differences approach, which is stronger than pre-post or ITS without a control group because it controls for trends over time and shocks that happen to both groups. Next. So this graphic is a classic DID design. So the effect of the intervention is explored by examining the level and trend of the slope of an outcome before and after the intervention compared across treatment and control groups. So it's assumed that the treated group would have the same trends over time as the untreated were it not for the intervention. So that is the orange dotted line. And any difference between the assumption of the trends that they would have and the observed solid orange line is the treatment effect. So this design requires the parallel trends assumption to be met. Trends in the treated and untreated group should be parallel prior to the intervention on the left. Next. So an example of difference in differences, there are also quite a few of these, was a comparison of estimated rates of COVID-19 in border counties in Iowa without a stay-at-home order and border counties in Illinois with a stay-at-home order. So these authors cleverly assessed the effect within a localized area to maximize comparability between the treated and untreated counties, which were contiguous. Next. So here is the cases per 10,000 residents in Iowa and Illinois. So the blue vertical line is the date on which the stay-at-home order took effect in Illinois. So before the intervention, they both had very low transmission. And then you can see that over time, the gap between Iowa, which did not have a stay-at-home order, widens from Illinois' cases. Next. So here are their results. They assessed the difference from the pre-period, which was from March 15th to March 21st. March 15th being the day that the first case was reported in those counties, to March 21st, the date that the stay-at-home order was issued. Then they estimated a model separately for 6 post periods, which you can see listed on the left there. So I'm not sure exactly why they estimated the model separately in each post period, but it could also be due to non-linear forms. This way they only had to assume linearity for a short time period instead of modeling correctly the exponential curve that we saw on the last slide. So their models included county fixed effects, which capture county time and variant differences, and day fixed effects, which capture daily changes that were shared between Illinois and Iowa. So in the difference column, you can see that the second column, you can see that they already found a difference in the first post period, and that widened over time, just as we saw in the graph. Next. So they did a number of sensitivity analyses as well, which I won't discuss in the interest of time, but that was a strength of their study, as well as the fact that they evaluated the parallel trends assumption and determined that it was met. Another strength of their study is that they isolated to the small geographic area to maximize comparability. Some potential limitations are differences in testing between the states and potential bias if other policies were enacted in one state but not the other state that were not controlled for. Next. So to conclude this section, before we move on to the pragmatic study designs, which we hope are an improvement on these studies, these three study designs did increase in robustness, but they remain plagued by similar issues. So the ecological fallacy, all of them used ecological data and were analyzed at a state or county level. The challenges with modeling infectious disease dynamics appropriately, including lags and nonlinearities, and the challenge with concurrent interventions that comes up over and over when trying to interpret these study results. So I think we're going to pause here for questions, if anyone has any, and then Margaret and Starley will talk more about the pragmatic designs moving forward.
Great, that was a great summary of where we're coming from and where we'd like to go. I wanted to open up the floor for questions. I see comments from Steve Gregorich. I don't know if actually, Steve, if you want to make this comment live or if you...
Sure, I was just going to say that there's also an opportunity here to incorporate switching replications in ITS design. So you basically, you stratify your analysis by locale. Each locale is a little bit different. They have different onset times. And if there's a delayed effect of a policy change and you observe a similar amount of delay in the effect across locales, then it's always a little bit difficult with the ITS design if you have delayed effects, because then it's the cause, you know, what's your basis for drawing a causal inference about the intervention onset or the policy change if it's really delayed. But if you find a similar delay across locales, then it helps to make an inference about it being a kind of a general effect of the policy change that was observed in a similar delayed way across sites. And so that it's just a real opportunity here, because we naturally have different pandemic situations in different geographic locations. So that's just, it's really one of the best ITS design enhancements, and this is kind of custom made for that in a way.
Yeah. And I think one of that. Yeah. Sorry, did you want to respond to that? No. Okay. Yeah, I think it's, you know, one of the things that's interesting about what both of you have brought up is just there's a lot of anger going on right now around some of the state policies that are coming out and the lack of data that's supporting them. And it does make me wonder sort of how much data is out there. And, you know, I personally haven't had time to run through everything that's been published, but I'm curious about summarizing that data and what we know to be working and what we don't know to be working and why they're making the choices that they're making right now. And so it's timely, this discussion, and I just want to say that that's appreciated. Did anyone else have a question that we want to throw out there before we get started? Okay. Because I think we can come back to some of the issues that you've brought up as we learn about the pragmatic designs as well. I guess, Margaret, I'm not sure if you and Starley are going to do the same as Jean and Kristefer and sort of have a combined presentation. So I'm going to go ahead and talk about both of you, introduce both of you, So Starley, who's going to get us started here, is an associate professor of epidemiology and biostatistics at UCSF. She's an expert in the quantitative and economic evaluation of health services for people living with HIV. She's worked on a number of large projects, including a large PEPFAR-funded grant to strengthen capacity and strategic information systems in Mozambique. She's been working on as a member of the SEARCH trial, largely responsible for the economic evaluation and cost effectiveness analysis. And she's the person I call when I get stuck on study designs. So it's going to be great to hear from you, Starley. And I'm just going to go ahead and introduce Dr. Margaret Handley as well, who's a public health trained epidemiologist and a professor in the Department of Epidemiology and Biostatistics and Medicine at UCSF. Her work bridges the fields of primary care, public health, and health communication for improving health outcomes and equity in healthcare. She is the co-director of the UCSF PRISE Center, the Partnerships for Implementation Science for Equity, which focuses on equitable translation of evidence into practice, policy, and public health. And she also teaches many of the courses in the implementation science program, including one with Dr. Shade on quasi-experimental. So with that, I'll give it to the both of you to present the next piece here.
Great, thanks so much, Sherry. And thanks to Kristefer and Jean for setting us up. So today I'm going to talk a little bit about cluster level interventions and what some of the considerations are in the area of COVID. So I would assume that most of you are very familiar with these designs, but if you're not, just a little primer. So the difference is simply that when we have interventions that are implemented at the level of a clinic or a school or a community, then it's often much easier to, or more appropriate, I should say, to randomize those units of analyses rather than to randomize interventions. Because, you know, if we intervene at the level of the community, then we should evaluate at the level of community. One challenge with this is that communities don't look dissimilar from one another, and to the degree that outcomes are clustered within communities, then we need to account for that in our analyses. And so all of the analyses that we do has to account for what we call the intercluster correlation, or the ICC. This is a really quick overview of something that takes weeks. So essentially we need to account for the effect of the group. So I wanted to use an example from a grant application that we recently submitted as a grounding example for this talk. And so essentially we found in Kenya that, as soon as they found that COVID was happening, they really wanted to do everything that they could to protect people in HIV care. And so essentially what they wanted to do was, to get drugs out to folks as much as possible, and then also to conduct as many of the visits as possible via telemedicine. And so they did a small pilot in April and May with high risk individuals, including pregnant women, those who were older, and those who had other conditions that they needed to address. And so in this proposal, we were wanting to roll out this intervention to a broader population of individuals, all stable patients in HIV care. So we had about 20 clinics, and there were about 8,000 people across these clinics. And we wanted, and we felt like it would take about 4 months to implement the telemedicine approach in each clinic. And so we wanted to figure out what's the best study design to do this. And this had huge implications in Kenya because telemedicine had been sort of introduced as a guideline several years before, but it hadn't really been implemented. And they felt like if they could make telemedicine work in the context of COVID, then it could really greatly reduce overall costs of HIV care moving forward. And now that nobody has any money, we anticipate there's going to be a lot less money for international HIV care going forward. All right, so in this setting, what we wanted to do was we wanted to randomize the intervention sites. You know, it takes about 4 months to roll up. We need to do baseline data collection during that time to figure out what was going on in the site. And then we wanted to collect data for approximately 2 years. And so we had, you know, 10 sites that were going to be randomized to the intervention and 10 sites that were going to be randomized control. And then at the end of it, everybody was going to get the intervention. And so that's what these different colors represent. So the advantage of this is that we can account for the clustering in our analysis. We can estimate either at the level of the individual or the population, depending on our level of interest. In this case, we were interested in the population level effects, but you can implement this in settings where you're interested in individual level effects as well, using a different analytical approach. The disadvantages of this approach is that it's difficult to adjust for period effects, like the effect of calendar time. And so in the era of COVID, we were really concerned that as things changed, both with respect to the disease as well as with respect to, you know, lockdown conditions, then we felt like this was not a study design that would really work. And then finally, only half of the sites received the intervention, and we felt like this was going to be an effective intervention. And so we wanted to roll out telemedicine as quickly as possible to all of the sites. So just to be, because this is an analytical group, I wanted to just cover sort of the analytic approach. So you can either use generalized estimating equations or mixed models in this setting. Generalized estimating equations, or GE, offer inference at the population level. It accounts for clustering at the highest level, but not at lower levels. And it's less biased if you have a small number of clusters. However, there are limitations which have to do with multiple levels of effects. So for instance, if you're interested in accounting for clustering, both at the clinic level effect, the provider level of effect, and the individual, then you might want to pursue mixed models instead. And mixed models doesn't allow inference at the level of the population. Instead, it's at the level of individual, but it does allow for you to account for clustering at multiple levels. It also allows you to investigate fixed effects at multiple levels. So you could actually investigate whether there were different intercepts and slopes across each clinic, for example. All right. So next, we wanted to consider a step-wedge trial. Step-wedge trials have become very popular, at least on paper, in the last several years. And the idea is that essentially it allows you to roll out the intervention over time in the settings where you work. And so you collect data in all of the clinics over the entire time period, but you introduce the intervention in a stepwise fashion till such point as all of the sites are implementing the intervention. And so this is the basic design. One advantage of a step-wedge trial is that in settings where you have highly clustered data, a step-wedge can actually give you more power to detect differences than in a parallel cluster randomized trial. Now, the reason for this is that you're essentially evaluating pre and post in each clinic, and so you're able to eliminate that within site variation, or account for that within site variation. So here was our thoughts in terms of the step-wedge design in our project. And so what we thought is that we would, it takes about 4 months to roll out, so we would roll out sequentially over time. And then each health facility would implement the intervention for a period of 2 years, and then we would do post-intervention rollout after that time in each setting. And so as you can see, and I'm hiding you in my, it takes about 40 months before you've rolled out the intervention. Oh, sorry, it takes about 20 months before all of the sites have gotten the intervention. So that's a much shorter period than in the traditional cluster randomized trial. So the advantage in this setting is that all sites receive the intervention relatively rapidly. It incorporates the reality of the rollout design. So one of the challenges that we were having was how many nurses do we need to do the training in all of these settings in order to be able to roll out the design. And so it would take us 10 nurses we were going to pair them together. So it would take us, 10 nurses to roll out in a traditional cluster randomized trial. But if we rolled out in a stepwise fashion, it would only take us about four nurses, because we would be able to stagger those across sites. Another advantage is that the stepwise design allows us to consider issues of both study and calendar time. So introduce calendar time into the analysis, and then you can look at those things together or separately. As I mentioned, it's less sensitive to high levels of clustering. Now, disadvantages, in our case, the biggest disadvantage was that our outcome was viral suppression. And so in order to evaluate viral suppression, you really needed to have a washout period for that duration that you wanted to look at your outcome. And so that can make the study pretty long, and we really wanted to get the study going as quickly as possible. There's a longer total study length because it takes a while for all of the sites to then roll out and then receive the intervention. And then finally, one issue that was a big issue for us was that it requires a substantial amount of data collected prior to intervention in the steps that are implemented later, because you basically have to collect data at all study points for all of the different sites. The analysis here is similar to cluster randomized trial, except that you incorporate calendar time. So it's generally that's used as a variable for step, but it can also be any other measure of time that you'd like. So what we ended up doing was, or proposing, was a matched cluster randomized trial. So in this case, we would roll out to 2 intervention sites and 2 control sites simultaneously. And so this allowed us, essentially, the idea was that we would do the training here in each site, but we would only have to train in 2 sites at a time. And so that, in our case, we felt like that would dramatically reduce our staffing burden, and it would also allow us to consider calendar time in our rollout. And then what we did was we just paired these 2 groups and these 2 groups and these 2 groups. So the idea was to get sort of the best case of both designs. So the advantage here is that the cluster randomized trial is appropriate for all types of outcomes. So we felt like it would be more appropriate for our longer term outcome of viral suppression, because really we felt like we needed to be able to follow people for at least 6 months in order to make sure that they were going to have durable viral suppression. Considerations included measurements, so there were fewer data collection that was going to be required prior to implementation. So in other words, we would only need to do a baseline data collection in each site. We wouldn't need to do sort of a long time series before implementation. The disadvantage here is that the data analysis is more complex. The traditional approach is sort of similar to meta-analysis, where you do a pooled estimate of the difference between the pairs. In the search trial, we ended up using targeted maximum likelihood methods, which are computationally challenging if you have a relatively small sample size. In this case, we would be able to evaluate both study and calendar time. And so we felt like that was the biggest strength in this approach. All right, so in the interest of time and the fact that I really love watching Margaret present on this next cluster of study designs, I'll let her go.
Thank you, Starley. Thanks, everybody. Let me get this going here. So I'm going to take us in. Can you see my slides?
Yes.
I'm going to take us in a different direction, but a complementary direction, I hope, and talk about things that are much more sort of focused on the individual and their choice and a choice design, and also and their response in the smart designs. And so I'm going to talk kind of from a design standpoint, but I'm going to give some COVID-19 hypothetical situations. So first, I'm going to talk about preference or choice designs. So why would you consider design that involves giving a participant a choice? So this can also be done at the group level, but I'm going to talk about individual level choice. And so this comes up in the context where you have more than one intervention or more than one intervention component. So thinking kind of in the COVID-19 context, like there's a lot of different things that can be done, which is great, but none of them are 100% effective. Are there ways that we can think about them as intervention components? Maybe they have similar efficaciousness. So in traditional clinical trials, this is a similar issue. There might be multiple groups that have different kinds of treatment preferences, but we often just randomize people to treatment A or treatment B and don't take into account the role of preferences. So preference designs, I'm going to talk about the kind that are a randomized clinical trial. There's also some other variants that are really interesting, but a little bit more observational. And I'm going to talk about them in the context that they can be used to evaluate how individual preferences may influence an outcome and how this might be separate than treatment effects. So this is just the general schema of a choice design. So you have a group of participants and they're randomized either to a choice between two or more intervention components, or they're randomized to another randomization step, which then either gives them those two or more intervention components. So if you think about that, it raises some interesting questions, like does having a choice influence your outcomes? Now, one of the assumptions of this, I think that's really interesting, is it does in sort of presume that everybody knows what it would be like to be in treatment A or treatment B. So with some kinds of things, it's easier to imagine certain kinds of treatment options like group therapy for mental health versus individual therapy. But this does involve, I just want to say, informed decision-making. So when people are put in this opportunity to choose, that they do actually have informed decision-making. So I think it's also really interesting, there's some other things you can look at here too. So thinking about, those who got to choose treatment A and those who were randomized to treatment A, is there something different going on there in terms of their outcomes? So does there actually have an impact of being able to choose on their outcome? And so this can be considered a preference effect. And so this could be the case where there might be greater adherence to something if you got to choose. You might feel more empowered in the context of that intervention than if you had been in randomization arm. So these are things that people can examine and explore in these kinds of two-stage preference designs. But you also can examine if there's a differential impact in the response just within the group that got to choose. So is there a selection effect? So like if you give people choice, does everybody pick one thing? Do they equally pick, proportionally these two different treatments? And is there then some interaction potentially with the outcomes that you're looking at based on being in either arm of that choice group? So one thing that this is useful for is if you're thinking about, resource allocation, maybe there's really different costs associated or delivery associated with treatment A and treatment B, but you don't really know how people prefer them. So a COVID-19 example, this is something that could happen. It's not currently happening, but if thinking about like contact tracing programs and trying to incentivize people to stay in quarantine, one could envision different models of giving people resources. So currently programs like San Francisco will give people food vouchers and sometimes hotel stays and some cleaning supplies. So sort of a resource package, that's one intervention. But there's also the opportunity, I think, we could look at, can you pay people to stay at home? And there was for a while a policy for cases that allowed people to basically get some compensation financially. So you could imagine a program where you could have an enhanced resource package and a cash stipend package. You don't really know if there are differential preferences here and how they might influence maybe getting that second COVID-19 test at the end of your quarantine period. So you could do a design based on this preference approach where you've given people the choice in a randomized fashion, and you've also randomized people to either of those two interventions. So do those who choose A or B versus randomized have different outcomes? Is there a different uptake overall, say in follow-up testing, if you've randomized people to choice or a second randomization? And are there differential uptakes if you give people that choice, that comparison within the choice arm? So for example, if you looked at those in the cash who were randomized to get cash and those who were given the choice of cash, are there different outcomes? Would be the kind of thing that you would be looking at in this kind of situation. Okay, so now I'm going to turn to this other design that I think is also really interesting, and this I think touches on some of the ideas about how can we roll things out in ways that learn from the experiences that we're having. And in that context, there's room in the SMART design is a version of a factorial design where interventions are reevaluated at a particular stage, and then there can be re-randomization. So this is sort of like learning about the intervention and then using that in a way to inform the intervention. So why would testing, and this is usually in the context of sequencing intervention components, like you get something and then you get something else and then something on top of that, why would that be useful? And so this is where, again, you might have a package or possible intervention components and they don't really have a clear sequencing. Maybe you give them all as a bundle, maybe you offer one or two and see what the response is and then you move forward if you don't get that much response. So this is the kind of idea of thinking about like, how can we learn and include more effective approaches to total dose or sequencing as we roll things out. So just a traditional reminder, sort of factorial designs, you might have like 3 in this example types of things that you're giving out there, and you can have different variants of it. So I'm going to show you an example in a minute about trying to get people to come in for an annual health visit. And so you can imagine text reminders, you could have letters sent, you could have follow-up phone calls. Each of those has different cost and staff involvement. So you'd be interested in knowing, like, do we have to give people all of these things, or can we just send them a text reminder and they'll come back in for their annual visit? So this is the idea where, do you have to create these kind of, full-fledged bundles, or can you maybe back it down a little bit? And what on the other hand is the right sequence of doing this? So this is the idea of how can you learn from these variants in a way more quickly so that you can use that information and move forward. So you're not just doing randomized trials of every single one of these things with lots of follow-up time, which takes a long time. So this one's called a 2x4x2 factorial, and I'll give a SMART example in a minute, but this is just to sort of ground you in the factorial, remind you design. So in this kind of situation, you're looking at, like an early time period where you've got this opportunity to send people these pre-notification texts, or you don't send them to them. And then you maybe have a control group. Then after a period of time, you send in these different letters. And in this scenario, they sent kind of customized letters like, you need to come in for your health exam, come in March. Others were more like, hey, check in, come into your health exam, and didn't require looking at patient data. And so then they also looked at reminders. So this is the kind of way you can see, like, there's different sequencing here, and there's different levels of intensity of like dose of contact. So these are the kinds of things that you can look at more quickly if you do this. And this was over, in this study design, it was a 2 to 3 week period of intervention total. So the SMART design is really where, if you think about that one we just looked at, after the text message happens and before the letter is sent, you learn about what happened when you sent that text message. So did people respond to it? Did appointment scheduling happen? We often just sort of let things roll out and then wait for things to happen. But what if you could anticipate natural stages where you might look at the uptake and then make a decision about whether or not you want to continue on with that approach to giving people this text messages or reminders, or you want to do something else. So again, this is the idea that you're thinking about sequencing with intervention content that, that has efficacious elements to it. So in this area, I think is really exciting because you can use information in the first phase to tailor something more to an individual if they're getting something generic and they're not responding. You can intensify it, you can replace intervention strategies. So this also, I think, is good for thinking about cost. So this is a scenario that I think actually is happening in some of the public health clinics, not maybe necessarily this design, but this idea about how can you learn from responses to the idea that because of COVID, there has been a lot of disruptions, as sort of Kristefer was saying, like sometimes we're reacting to the disruptions that have happened in the way people are naturally delivered care. And let's try to make sure we're not reducing equity when we respond. So this is something where you might have a telephone visit or a video visit, video visits being more intense and harder to schedule. So people might be randomized to get either one of those. And then you have this kind of window here where you're evaluating what happened to those who were randomized here. And this is, again, sort of based on individual randomization approach, but could be also done in cluster randomizations as well. Are people doing the phone? Did people go in and have that telephone visit, or did it not seem to be that there was any response for that and people didn't show up for that? So you can take that information and then you can decide that you're going to re-randomize people if they didn't have a high response to the visit. Or you could say, no, that telephone visit worked. You know, we did a quick check-in, they're fine. We're gonna keep on with that. But the point here is that you would let those people who were doing great, you wouldn't do more to them. You just say, okay, you're fine. You let them stay on. And then here's where you have the opportunity to sort of re-randomize. And this is where you can be creative. And I think there's a lot of things that can be done in this space where maybe you're randomizing back to the same. You're just going to see if maybe more time of that exposure helps. Or maybe you're randomizing to move over to the other one, the video. So a lot of times these involve just going to the other, maybe more resource intensive intervention style. But they also could be to something completely different. You can decide that you're going to bring in health coaching calls, which maybe are less expensive than the video to set up or to do, or maybe you now have the infrastructure to do them. And so you can potentially change the intervention that is delivered here. And so the idea of this kind of design is that it allows you to roll things out, but learn about what's happening with intervention components and allow you to then be responsive. So, you know, in a perfect scenario, all the different components that, you know, that we saw in the difference designs and interrupted time series that are all clustered together, you would move these through, you know, in some kind of way like this, where you could sequence things correctly. Now, we can't do that in lots of situations, which is why we have so many of the study designs that are quasi-experimental that are much more ecologic. But there are opportunities, I think, to be thinking about how can we embed maybe learning about interventions at important points in time as we move forward, and thinking about designs like the SMART design or the preference trial help us do that. So yeah, this is just an example of does adding the video to telephone increase overall proportion of those in getting some kind of a visit versus alone. So there's a lot of different questions you can ask. It's just an example of one that this study can help answer. I think that's my last slide, so I'll stop there.
Great, thank you so much. I was thinking while, oh, there's the poll just popped up. I was thinking while you were speaking, while Starley was speaking, that it'd be interesting to sort of tie some of these study designs back to sort of COVID and think through how facile sort of each design is given, you know, an interruption in the middle. And we did talk about this a little bit in session 3, but, you know, when you can account for calendar time in some of the designs that Starley was presenting, but then if you also have to account for like the sudden onset of COVID, you know, are we just talking about dummy variables? Is there one design that can help you tease that apart better than others? Or is it really all in the analytics that comes down to if you have a design that takes calendar into effect? It's a big question.
Yeah, unfortunately, there's no real way to separate calendar time from COVID time necessarily, right? Because they're essentially linked. I mean, if you have, I mean, I think that they addressed this pretty well in the last session, but like if you had an interrupted time series design and you had seasonality, you could theoretically evaluate out seasonality, but you would still be, you know, left with, and so you could theoretically then infer that any remaining difference was due to COVID.
Mm-hmm.
But in the cluster randomized trial design, you know, or the step wedge design that I was presenting, even in settings where you can account for calendar time, you're not really going to be able to separate, you know, a trend from the real change due to COVID. I mean, right. That is a limitation of all of these designs, I think.
Yeah. Thanks. I see also a question in the chat. Kristefer, do you want to?
Thanks, Sherry. Margaret, I was curious about the SMART design, and I know we've talked about these before, but can you incorporate choice into those? I was just thinking about like those visits. If the telephone visit doesn't work, could you then be asked or offer a choice to say, do you want to continue or should we switch you, and then kind of see what occurs with that decision?
I mean, I think that's a great idea. I mean, that's an example of something. I haven't seen a study that incorporates that. I mean, just looking at this kind of design in general, it's kind of a new design. And I think it provides a lot of opportunities to blend components, especially if you're thinking about scenarios where you have multiple components and you don't, you know, they seem equal or they seem like not inferior to each other. There's no reason not to allow a variety of approaches. And I think I really think choice is an underutilized methodology. It does, like I said, mean that people kind of have to know what they're getting into to be able to choose, you know, effectively. So that's an important piece that has to be considered. But I think they're a really exciting variant and aren't just like standalone designs like you're suggesting. They could be brought in. Yeah.
Great. Does anyone else want to jump in with a question? Then I will continue to ask my questions then. I wanted to sort of loop back around to the beginning of the presentation and the data that policymakers are using right now to try to figure out sort of what's going on with COVID. I don't know that any of the newer designs that Margaret and Starley have presented have been in use to date in looking at COVID data, but I'm curious if in your lit review you're finding some of those, and if they're giving us any better sense or any better able to tease apart some of the various interventions that are obviously coincident, so it's hard to tease them apart.
Yeah, that's a great question. And it was part of the impetus to write the paper. So we looked, when we did the lit search, I think I last updated it earlier in the fall. So I don't know like today if there's been anything published, but we looked, for example, for step wedge designs, and there were none. It was really limited to those early 3 study designs that I shared.
Yeah, I mean, we have been really interested in, it seems like school rollout and studying the school environment in different counties, kind of like those earlier ones, which they took the natural opportunity of looking at the counties in different states that were near each other that Jean mentioned, but the idea of looking at different districts for different states and school rollouts using stepped wedge or stepped wedge with smart trial variants where, you learn about, what happened in stage 1, that kind of thing. There have been some proposals for that. I know San Francisco has had some really nice ideas put forward by Naomi Bardich and others that, if we didn't have to sort of lock down again, we might be able to be looking at for the public school system. But to me, that's like a very obvious one that should hopefully be out there. And maybe there are examples that we can find, but I haven't seen any.
Yeah. Would be interesting. Anyone?
Yeah, if some philanthropist wants to come along and give a lot of money to the contact tracing programs to allow people to be paid to not have to feel like they need to go to work and lose time and those other issues that come up about rent. So that, to me, there's a great opportunity for some enthusiastic philanthropists to see a preference design in action.
Well, let's all hope that there's someone out there listening, some enthusiastic philanthropists, more of those.
Exactly.
Just want to open it up if anyone else has another question. It's been really, motivating, at least for me, to look through some of the study designs that you're talking about and just think about how I could use them in future research. Anybody? Okay. Well, then I hope everyone fills out their poll that popped up on your screen. If you lost it, you can send a note to Rochelle and she'll resend it to you. And just a reminder that we'll have all of these posted on the CAPS website, on the I&I Core website, hopefully, and potentially cross-posted with the other sponsors if we can work that out. So I really appreciate everyone's time today. And especially our speakers, thank you so much for joining us.
Thanks for having us.
Thank you. This was
Thank you.
lovely.
Thank you.